let me not delay and let me get us started. It is a great pleasure for me to introduce Dr. Salusky from UCLA, who graciously will be talking to us tonight about the renal aspects of rare bone disease. Thank you so much for being with us.
Okay. Thank you, Dr. Tosi. Good afternoon, everybody. It's nice to see a few faces that are friends from many years. I see Dr. Collins in the audience, so for him, I will say a few words in Spanish so he's able to understand my talk a little bit better. But that only will be specifically for Dr. Collins. So what I want to do today, it's a difficult question when they ask me about renal aspect of rare bone diseases. Initially, I thought about that I was planning to give a talk on chronic kidney disease, the type of topic that I do all the time. But then suddenly I realized that this has nothing to do with chronic kidney disease in one aspect. So so what I was planning to do today is just to focus on selected lifelong renal phosphate wasting disorders, because I think we have made major progress in the understanding of these diseases over the last several decades, but a number of these patients really have long-term complications now that they get into the adult age. And then I would like just to discover a little bit the impact of the identification of FGF23 in the pathogenesis of these disorders, highlight the long-term consequence associated with conventional therapies, and because as I mentioned before, there are a number of significant complications that have impact on the quality of life of these patients. So I will focus on three main diseases today that I feel that we have made some significant advances in the understanding of the pathogenesis of the disease.
Dr. Salusky, I want to interrupt for a moment. Sorry, we are not seeing any slides.
Oh, you're not seeing my slide?
No, yeah.
Oh, that's a problem. But you saw it before.
We saw it before, yeah. All right, yeah, we were seeing your, that looks good.
Yeah. Now?
Yes, we are, perfect. Thank you so much.
Okay, I'm sorry, I apologize. So basically what I want to, thank you for letting me know. So I will highlight the focus on three main diseases, cystinosis, hypophosphatemic rickets, and generalized arterial calcification, GACI. The audience here is very wide, and I didn't know a little bit about, so I thought it would be important just to focus on the factors that regulate calcium and phosphates and vitamin D, the interaction between parathyroid glands, the kidney, and the intestine. And I think what is important to understand today is that we have the traditional PTH vitamin D effect on the regulation of calcium, phosphorus, and vitamin D. We know that decreases in serum calcium stimulate production of PTH. PTH has really important action directly on the kidney. One, by stimulating the 1-alpha hydroxylase, and this one production increase the production of 125, and by increasing the production of 125, we increase intestinal calcium and phosphorus absorption in order to one of the other factors to suppress PTH, and obviously 125 has direct effect on parathyroid hormone secretion. In addition, 125 has a direct effect on bone by increasing osteoclastic reabsorption to release also calcium and phosphate from bone in order to have another effect through calcium for the suppression of parathyroid hormone. And also what is important is that PTH has a direct effect at the tubular levels, the proximal tubes, and sodium phosphate cotransport in the proximal tube that diminish renal phosphate reabsorption. So it's a phosphatiuric hormone, and it's important to remember also that they stimulate the 1-alpha hydroxylase by producing more 125. The other hormone, which I think is very important, and to me, this hormone was identified in the year 2000, and FGF23. And I think it's a fascinating story because you can see in a period of 15 years from the discovery of this hormone through specific genetic disorders, now we can see there is an antibody for the treatment on a specific therapy of a disease, which in a period of evolution of 15 years is pretty impressive. And FGF23 really, different factors stimulate the production of FGF23. One of the I think is important one is, in this case, we are going to focus on phosphorus, but there are many mineral factors like vitamin D, calcium, non-mineral factors, iron, epogen, that I don't have time to discuss today. But the important thing to keep in mind also is that FGF23 is produced by bone, by osteocytes, and has a direct effect on the kidney. And this is an effect which is it inhibits the 1-alpha hydroxylase, and on opposition to PTH, and also as PTH has a phosphaturic effect by diminishing renal phosphate reabsorption, and by then increasing sodium phosphate excretion. So what I want to do today is just focus only on the tubular phosphate transport for these diseases, that all the abnormalities happen at the level of the proximal tubular phosphate. And as you know, there are two sodium co-transporters, the NaPi2A and the NaPi2C, that play an important role in tubular reabsorption of phosphate. Almost 90% or more of the tubular reabsorption of phosphate, it occurs through NaPi2A. Now, the first disease that I will talk about is a disease that affects globally the tubular proximal reabsorption of many factors. And that disease is cystinosis. Cystinosis is a storage disease due to mutation, the cytosine gene, encoding a lysosome that is a cystine transporter. And then because of that, there is cystine accumulation in all organs, primarily the kidney. There is a global effect at the level of the proximal tubule that leads to Fanconi syndrome. And then these patients have progressive kidney disease, and they lead into dialysis and transplantation. Now, many years ago, the identification of the treatment with cysteamine, which is cystine depleted agents, has really changed the course of the disease, because it has delayed profoundly the progression of chronic kidney disease. But the hypophosphatemia, despite treatment with cysteamine, persists. For those of you that don't remember exactly all the characteristics of Fanconi syndrome, these patients have polyuria, polydipsia, hypophosphatemia, hypokalemia, hypochloremic metabolic acidosis, and aminoaciduria. Today, we are going to focus mainly, obviously, in the effect of the hypophosphatemia in the context of this disease. And I would like to highlight the work that I did in combination with a group at NIH, Mike Collins and Pablo Florenzano, in which we have undertaken a comparison of the biochemical parameters in a large cohort of patients with nephropathic cystinosis and a group of patients age-matched control and also with the same degree of chronic kidney disease, with chronic kidney disease secondary to different causes, obviously, but not most of them are renal dysplasia, obstructive uropathy. So the black bar represents those patients with cystinosis. The gray light bar represents those patients with chronic kidney disease. The x-axis represents a stage of CKD from mild CKD to more advanced chronic kidney disease. And then here you see very clear the first slide on the left, the tubular reabsorption of phosphate. And you can see very clearly that despite treatment with the standard therapy for this disease, there is a significant difference in the tubular reabsorption of phosphorus between patients with chronic kidney disease and those patients with cystinosis, so that clearly demonstrates that these patients continue to lose a significant amount of phosphorus through the urine. And the serum phosphorus levels are lower in these patients, And when you calculate the serum phosphorus by Z-score corrected by age, you can see significant difference between the patients with cystinosis and those with chronic kidney disease. Now, this also is very important because when we look at the level of FGF23, either with the, when this case was the C-terminal assay, you can see values are lower in cystinotic patients compared to patients with chronic kidney disease. We know that in chronic kidney disease, as the disease progresses, the level of FGS significantly increase, and they are extremely high in patients treated with maintenance dialysis. And those values diminish at the time that kidney transplantation. And there is a whole, the FGF23 really plays a key role in the pathogenesis now of the kidney diseases associated, of the bone diseases associated with kidney disease. But as you can see here, what this data clearly demonstrate that the role of phosphate in the regulation of the 1-alpha hydroxylase and serum phosphorus levels. And you can see that this effect of phosphorus in the regulation of FGF23, I'm sorry. So the lower serum phosphorus, really the production of FGF23 is markedly diminished. Similarly, serum PTH tend to be lower. Again, phosphorus is another important regulator of parathyroid hormone secretion. And it was also very interesting, as expected, that level of 125 are higher in patients with cystinosis compared to patients with chronic kidney disease. So this kind of, I really think these data are very interesting because it really shows physiologically, which these days we do very few studies on physiology in patients. Clearly, our current understanding the regulation of PTH and FGF23 in the context of chronic kidney disease, and mainly in a group of patients like the cystinotic patients in which there is persistent hypophosphatemia. Now, also, we did bone biopsies in these patients, in one of these patients, and that was a study that we did also previously, with a group at NIH, in which we can look also at long-term consequence of the disease on the skeleton. And basically what I would like to show you here, what you can see here, that these patients, the light blue here, have a significant amount of osteoaccumulation. So there is, and when you look at the tetracycline labeling in the bone biopsy, there is minimal single label of very light tetracycline uptake, which really those findings are consistent with a severe defect of mineralization, and are consistent with finding with osteomalacia. Also, we can look in the marrow how the cystine, where there is cystine accumulation. And then when you do polarized light, you can see this white dot, you can see very nicely the cystine accumulation. So, and this is very important. These are patients that receive treatment for many, many years. And the consequence is that there is cystine accumulation and the skeleton continue to have this severe defect associated with the mineralization defect. Another important thing that happened in a number of these patients is that they develop nephrocalcinosis, as shown in this part of the slide, or nephrolithiasis, which also these are probably a consequence of treatment with active vitamin D, phosphate supplementations, and how also sometimes patients are monitored, which is very important. But these patients over long periods of time, like happened with other diseases treated with active D and phosphate supplementation, that patients develop nephrocalcinosis, and it's important to monitor very closely. But what is important also, the consequence on the skeleton of this disease, and as you can see, again, this I want to remind you that these are data from patients from NIH that we worked together with them a number of years ago. And you can see here the axial skeleton, this severe scoliosis. These are the appendicular skeleton. You can see bone deformities. And also when they did a bone density study of the lumbar spine, the open circles represent patients that receive a kidney transplant. This is a cohort of patients from NIH, and the closed circles of patients that didn't have a kidney transplant. But this is the Z-score for the bone mineral density, and you can see all of both groups. They are not different between both groups, but both groups the bone mineral density significant decrease compared to sex, age, and ethnicity match control. So there's no question that these patients over time develop persistent osteopenia and low bone mineral density. Why this is important, I think, today is because there are groups now trying to describe a specific, they call them cystinosis metabolic bone disease. And they say, obviously, characterized by short stature, osteomalacia, bone deformities, bone pain, osteoporosis, rickets, and in adults, long bone fractures, scoliosis, and low bone mass. The factors involved in the pathogenesis of these disorders over long periods are multifactorial. But there's no question in my mind that a persistent hypophosphatemia play a critical role. And there are many others, from nutrition to inflammation, hormonal disturbance. This is a very complex issue that require, a number of different thinking about how we are going to approach the future of these patients, because these patients, as they become older, they are having a number of these metabolic complications, and they are sometimes very difficult to treat, and we don't have the appropriate strategy for the money or the prevention of these long-term complications. And I think, in my opinion, like in many other diseases in which we have made tremendous advances over the last 20, 30 years, and these patients are becoming young adults, a number of these patients have complications from the disease, and sometimes our adult colleagues are not very sensitive in the understanding the pathogenesis of these problems. And I think this is a very important, an important area that in the future will be very critically important, that we continue to work very hard in order to understand the transition from children to adulthood, and who are the appropriate physicians that will monitor this patient. Now, in this disease, now there is a new, maybe possibility of new therapy. With gene therapy, there are interesting results in mice. And I know that clinical trials are done at the present time. Whether this will be the future, I don't know. We don't know much about the results of the studies. I know that there are a few patients already underwent treatment, but this is something, whether this will correct the Fanconi syndrome, the hypophosphatemia. These are very important questions that at the present time, we don't have an answer. So that's in one way what I would like to mention about cystinosis. The other group that I would like to mention are those patients that develop rickets. As you can see here, there are different types of rickets, but the radiological manifestations are the same, regardless of the primary cause of the disease. We know with bowing, deformities, sprain, these are classical signs of rickets. Now, for the understanding of hypophosphatemic rickets, really we need to think about two main components: those who are associated with elevation of FGF23 levels, and those who are associated with normal level of FGF23. And among those who are related with elevated level of FGF23, the most common is hypophosphatemic rickets due to FX mutation. And there are other forms of rickets, autosomal dominant rickets, and that are less common. But today, I will try to focus mainly on the group of these with FX mutation, because of the change in therapy that have occurred over the last few years in this patient population. And just to remind you about this issue of phosphate homeostasis, I told you that this disease is caused by excess of FGF23 produced by bone that have a direct effect on the kidney because it inhibits the 1-alpha hydroxylase. Therefore, the level of 125 tend to be lower compared to another patient with the same degree of hypophosphatemia. And this also FGF23 blocks the sodium phosphate cotransporters, and therefore it enhances urinary phosphate excretion, similar to parathyroid hormone, with the difference, as I mentioned before, that PTH stimulate the 1-alpha hydroxylase, increase the synthesis of 125, and stimulate NaPi2b in the intestine to increase intestinal calcium and phosphate reabsorption. So we know for the last several decades, conventional therapy for hypophosphatemic rickets is being used with phosphate supplementation and active vitamin D steroid. This is conventional therapy that is being used for many decades. And with the identification of FGF23 over the last few years, an antibody, a monoclonal antibody to FGF23 has been developed, and it underwent clinical trials. And this is one of the studies in which burosumab is being compared to conventional therapy in children with hypophosphatemic rickets. The blue bar represents those patients treated with burosumab. The purple bar represents those patients with conventional therapy. And the y-axis represents the change in serum phosphorus since the initiation of therapy. So this conventional therapy was active D and calcitriol and phosphate supplementation, and burosumab was given to these children every 2 weeks. So you can see that within a week or two of therapy with the antibody, the serum phosphorus levels are within the normal limit in the vast majority of the patients during the period of follow-up of 64 weeks, and values did not change in the conventional therapy group. When they look about, they establish a way of looking at the X-ray score by a group of independent radiologists who develop a specific score. It doesn't mind. I don't want to go over the score, but you can see very clearly that when they did X-rays on these patients, you can see that the purple bar, the one with conventional therapy, there was not major change, and there is significant improvement in the radiological score with the burosumab therapy. Similarly, the lower limb bone deformity was markedly improved with therapy with burosumab. And thus, improvement radiologicals are also consistent with changes in alkaline phosphatase. And the change in alkaline phosphate, you can see that decreased significantly in the group of patients treated with burosumab. In one way, I will assume, since we don't have in this group of patients bone biopsy, but it's a sign that the osteomalacia is healing. A bone biopsy is done in a cohort of adult patients undergoing similar treatment. It's been shown that bone histology, the indices of osteomalacia are markedly improved in such patients. So it seems that is a beneficial effect of the drug that you can give it twice a month versus another medication you do every day, 4 times a day, et cetera, that with all these problems associated, on one hand, with the medication, probably sometimes some of the patients develop nephrocalcinosis or nephrolithiasis, and then adherence with medication, which is a big problem, mainly for these adolescent patients. Now, this medication, as of a few months ago, is not accepted in all countries around the world. These are at least what I found, what region of the world this drug is accepted for utilization for patients. So it means that also there are a number of patients that need to continue treatment with active vitamin D and steroids. And I think it was very important in this group of patients is that we think about ways to prevent hypercalciuria, hypercalcemia, nephrolithiasis, nephrocalcinosis, secondary hyperpara. And obviously that this issue is by monitoring these patients very closely. That's the only way that we can prevent these complications is by appropriate treatment and monitoring. And sometimes, as you know, families get tired, and there is a lot of this is a very complex issue, and entails a significant involvement from the family also in trying to understand the long-term consequence of this disease and how we can prevent complications. A number of years ago, even there were a few cases that some patients developed end-stage kidney disease. Personally, I have one patient that underwent kidney transplant with hypophosphatemic rickets many years ago because of complications with nephrocalcinosis, etc. over time. So this is something which I think those patients that we continue to treat with phosphates and vitamin D are extremely important. Whether this therapy, whether long-term therapy with the furosemide, there are a number of things about such therapy that we don't know. And obviously, I think that group of patients also deserve long-term follow-up, and that it has to remain to be evaluated. The initial results seems promising, but there are a number of things that still, over the long-term follow-up with this therapy, that we don't know. So the other disease that I would like to make some comments is also a very rare disease called generalized arterial calcification of infancy. And I'm glad that Dr. Ferreira is in the audience. I saw his name there. And that the group has recently published a number of very interesting summaries of the natural history of the disease in a large group of patients. But what is important is that these patients have severe, some of them present very early in life, in the newborn period, with severe calcifications. And then over time, this calcification with treatment usually has been used etidronate. Some patients did not receive any treatment, and it got also better. But over time, these patients develop hypophosphatemic rickets. And this hypophosphatemic ricket is characterized also with elevated level of FGF23. The pathogenesis of this is not clearly understood, and the therapy for this problem is therapy with active vitamin D steroids and phosphate supplementations, like it affects mutation. And I will come back to therapy for these patients, additional therapy on this patient, when I will discuss the clinical case that I will present to you today. The other forms of rickets that have hypophosphatemic disorders are those related to normal level of FGF23. And the most common of this disease is the one that there is a mutation on NAPI2C. And these patients, really, the main characteristics are they have hypophosphatemia. Sometimes they can have nephrocalcinosis, but they have hypercalciuria. And so this is very important. They have hypercalciuria, and nephrocalcinosis, and develop kidney stones. And they can have rickets and skeletal fractures. And the treatment of these patients, obviously, is only phosphate supplementation. So when we look about the pathogenesis of this disorder, it's important to think about what happened here at the tubular level. So the mutation is in NAPI2C. And this really, so you can see that you have dietary phosphorus that is absorbed through the intestine, and phosphoroplase values are low because there is increase of diminished renal tubular reabsorption of phosphate. But this renal tubular reabsorption of phosphate is associated also with hypercalciuria. And there is a stimulation of 125, and that would lead to suppression that leads to the enhanced hypercalciuria. And the treatment of this patient is only with phosphate supplementation, and the active vitamin D steroids are contraindicated, obviously. So this is a rare disease, but I think it's important to keep in mind in the differential of these hypophosphatemic rickets in the workup of any patient with hypophosphatemic rickets. So I will stop here and I will present the clinical case. Is that correct? That's what you would like me to do? Or I'd be happy to answer any question before I move to the clinical case. What do you think?
Yes, thank you so very much. That's terrific. We will take a quick stop off right this minute, just to bring everybody up to date, since a few people missed our welcome. So welcome back, everybody. It's grand to have you here and to have such a fascinating talk. First, couple of just practical issues. As always, please be sure that you have signed in because otherwise poor Michael will suffer. And the usual opportunity to get pre-CME will occur a little bit later, and please be sure to take advantage of that. Also, please be sure to join us next month when Dr. Valerie Cormier-Dare will be talking to us about the prenatal diagnosis of skeletal dysplasias. Finally, a sort of little blast, which is I'm at the International Osteogenesis Imperfecta meeting in Sheffield, England, and this is a great meeting for those who are interested in OI. It won't occur again for 3 years, but I hope you'll join us wherever they decide to have it. It's been great. Now, let's take a quick minute and just see if anyone has questions. Oh, just don't be worried. Because the cases that are going to be presented have been published, we are going to continue to record this meeting. So should you want to come back to it, you'll have the entire show, which is a great thing. All righty, now, we're a relatively compact group. Would anyone like to make a comment or ask a question? I don't see anything in the chat. All right. Then why don't we continue and see?
Laura, can I ask a question?
Yes, please.
Hi, it's Mike Collins. Hi, Isidro. Isidro, can I ask you a question about your experience with the resolution of nephrocalcinosis? Does it ever resolve? And also, how often do you see it progress, just nephrocalcinosis, to renal insufficiency and or renal failure?
Yeah, that's a good time, Michael. This is a very good, it's very rare. It's extremely rare to progress to end-stage kidney disease. I think now those cases that progressed in the past, I think most of them was lack of appropriate follow-up, I will say. Rare now we see very, very uncommon, progression in this group of patients of nephrocalcinosis. Even very few of them develop nephrocalcinosis. So I think the fact that we are monitoring these patients more frequently, has an important effect. Now, the issue of whether they disappear, it's rare to see that they disappear over time. Sometimes, with other type of nephrocalcinosis that we see, depends on the cause of the nephrocalcinosis. In this kind of this disease, I would say is unusual these days. There are other diseases that you see nephrocalcinosis, like oxalosis, for example, that depends when the patients are diagnosed. When it's advanced kidney disease, it's impossible that will never disappear. And those kidneys are, loaded with calcium and phosphate. So that also, I would say, it depends when the disease is diagnosed and what are the type of treatment and follow-up that happens subsequently. I'm not sure I'm answering completely your question.
No, that was good. That was helpful. I mean, my takeaway is that it rarely progresses, it rarely resolves, but occasionally does, but to some extent, it's still an open question.
Yeah.
It is Francis Glorieux. May I make a comment on that?
Sure.
Okay. I've been looking at that in our populations as well. And in my experience with over 120 XLH patients, I've seen a certain proportion with nephrocalcinosis, but which have no impact on the renal function itself. So it's an image, but it doesn't have a functional impact on the renal function in most cases. The proportion of those with nephrocalcinosis in the XLH is about the same as the one we have found in pseudodeficiency, the 1-alpha hydroxylase defect. So I have looked at that and think that it's mostly linked to the calcitriol administration rather than the phosphate playing and treatment. But again, it's an image. I think that I've seen probably with both groups together, close to 100 cases of nephrocalcinosis. And only in one case did it have, there was a significant deficiency in renal function, but that particular patient had had vitamin D intoxication in the early stage of her treatment. So I think that we have to play it off. Myself, I don't even bother taking the image in the follow-up of my patients. I'm following the renal function very closely, but not the nephrocalcinosis, because it has never impact on my decision in treatment.
You know, to me, I agree with you about the follow-up is the calcium creatinine ratio. You know, that's the most important thing that we need to follow in these patients.
Yeah.
Now, whether you do an ultrasound, yes or no, I personally tend to do it every few years, just to see how are they evolving. But I agree with you. I think the main issue is close monitoring. I think these patients require close monitoring, mainly all during this period that are getting active vitamin D steroids. Then when they become adults, the issue with active vitamin D is kind of, many of them, they stop taking the vitamin D.
Yeah.
Some of them, they want to continue taking for one reason or the other. And so, yeah, I agree with you. I totally agree.
Thank you, Isidro.
You're welcome. Nice to see you, Francis.
Same here.
Great discussion. Thank you all. All righty. Are there any other questions or comments? All righty. Well, then let's keep going and please present your first case.
Okay, so the case that I will present is the following. Is a child that has a neonatal presentation with congestive heart failure and calcification of the aortic valve, aorta, pulmonary, and abdominal arteries were observed. And in this patient, you know, they was diagnosed to have an ENPP1 mutation. Therapy with etidronate was initiated. And over the years, vascular calcification really markedly diminished. The child was growing well. And at age 13, he presented with hypophosphatemia and bilateral henuvalbum. The degree of the henuvalbum required orthopedic surgery and therapy with calcitriol and phosphate supplementation was initiated. This adolescent got some issues with compliance with the medication. And at age 14, due to persistent hypophosphatemia, he has elevated FGF23 and also poor compliance with conventional medication. We decided to start the burosumab. And calcitriol and phosphate supplements were discontinued. The patient continued on etidronate for another 8 months while receiving burosumab, and that was subsequent was discontinued because etidronate was removed from the market. And these slides show the change in serum phosphorus since the low 2s before therapy, and you can see during this 18 months of therapy, the serum phosphorus levels were within the normal range. Now, what happened also is that we did an echo, we follow echo on these patients, and before and after therapy with burosumab. And so the B1 and B2 show the aortic valve at baseline. They have some minimal calcifications, but you can see during the period of 18 months of therapy, the calcifications markedly increase. So we were very surprised to see this change in the calcification. Obviously, the medication was discontinued. And I think this this was done 2-3 years ago, something like that. And then that it's very important to keep in mind that these patients with ENPP1 mutations, they develop hypophosphatemia. And it's important to keep in mind that the fact that there is some potential association between the improvement in the vascular calcifications and the persistence of hypophosphatemia. So it may well be that the fact that serum phosphorus increase play a role in the development of vascular calcifications, increase of the vascular calcifications in these patients. So I think at the present time, it's important that only patients with FEX mutations should be treated with burosumab. And we learned the story at that time. I was kind of excited about the antibody and the problem with this child and the compliance with medications, etc. So at that time, I thought that would be the best for him to have an injection every couple of weeks. But there's no question that the calcification gets worse. And I think it really raised this issue that this therapy, again, should be used only in those patients with FEX mutation. And I will stop here and answer any questions about it. Maybe Dr. Ferreira can make some comments about it.
No, I think that was great, Isidro. I mean, and
Well,
I
thank
think,
you, Carlos. Yeah.
yeah. No, and like you said, we actually had concerns that this might happen even before you reported the first patient. We actually have a second patient, as you know, that we never published. That she's an adult woman in her early 40s who also got burosumab and got worsening of, in her case, aortic valve calcification. The other theoretical possibility is that there is some literature in animals, at least, that when you bring down the FGF20, or that FGF23 regulates the local levels of alkaline phosphatase in the microenvironment of cells. So the risk might be that if you bring down the FGF23, the local alphos will go up, and that will cleave more, pyrophosphate, and your pyrophosphate will go down even further. That's favoring calcification. I recently had this discussion with Michael White, actually, because he was making the argument, well, but systemically, your alkaline phosphatase will actually go down if you give, burosumab, in theory. But again, there's animal data, at least, that the systemic and local levels of alkaline phosphatase don't really correlate with each other. And there's actually data that when they ablated only local levels of alkaline phosphatase of ALPL, knockout mice, conditionally only in the vascular, in the vasculature, that actually led to calcification, but the systemic one didn't really. So again, that's kind of like a convoluted story, but it could be the case that there's other mechanisms leading to arterial calcification in these patients because of the further drop of pyrophosphate if you give burosumab.
Did the vascular complications improve once you stop the burosumab, or is that a permanent change?
It seems I have repeated the echo just a few months ago. It's getting better. It's improving. It's improving. But this happened just over the last few months. So I would like to wait a little longer and see. Now the chart is basically on phosphate supplementation, traditional therapy, and I will have to wait. But it seems that it's getting better. A cardiologist saw him a few weeks ago. He was very happy with the echo. So it seems that he's going in the right direction, but I'm still a little bit concerned about it. Yeah.
And that's very interesting because that's what we see in kids. They're born with massive calcifications and suddenly it gets better after birth. And we don't know why. Maybe it has to do with placental alkaline phosphatase, that again, further brings down the pyrophosphate in the last trimester of pregnancy. But, and then once that disappears, once you're born, you can actually start kind of getting rid of or accumulating a little bit more pyrophosphate, but that's all theoretical. But I can see that Rachel also is there and might want to comment. Rachel sees all of our patients here with the ENPP1 deficiency.
Hi, I raised my hand, but it's a little bit hard to see.
Yeah, I see it now. I see.
Hi, Isidro.
Rachel.
Great talk. I just wanted to comment that I think, just to point out, and I think that probably most people on the call are aware that there are some other FGF23 mediated hypophosphatemic disorders for which furosemide is either approved or certainly being considered. I agree, it's not really recommended at this point based on the evidence you and Carlos have discussed in, or the potential concerns in the ENPP1 mutation patients, but it is approved for patients with FGF23 excess due to tumor-induced osteomalacia. Sure. And there are ongoing studies, including by Dr. Tosi and myself, in patients, and a couple of cases that have been published in patients with cutaneous skeletal hypophosphatemia syndrome. And it may be an effective therapy in some of the other very rare forms of FGF23 mediated hypophosphatemia, and potentially also in, and maybe in fibrous dysplasia and other disorders. So I think that there are going to be other potential uses, but it doesn't seem to be in the ENPP1 mutation patients. I did have a question. Did you say that this patient was treated with etidronate for 14 years?
Yes.
That's quite unusual. And so I was just curious, because I don't remember the details of this paper, but was the patient treated cyclically with etidronate or continuously? Because certainly continuous etidronate therapy would also cause rickets and osteomalacia. So I was a little bit curious about that.
He was treated, if I recall correct, and I will double check on that. I have the impression that he was treated continuously, but I'd be happy to double check and get back to you.
Yeah, because certainly etidronate is continuous etidronate is certainly a risk factor for inadequate mineralization.
Again, a great discussion. Thank you, everyone, for participating. Super. All righty. I think we have another case, yes?
Yes, I have another case. And this one, I did this case for Dr. Collins. So this is a 52-year-old woman with end-stage renal disease due to Alport syndrome that was diagnosed when she was 14 years of age. She underwent 3 kidney transplants. The last one was 12 years ago. But when I saw her, she has a total time on dialysis of 30 years. And she was referred to us because she has a fracture of the left tibia fibula with poor healing for more than a year. And also has a previous history of multiple fractures on the hip, the pubic ramus, the metatarsals, the metacarpal, but mainly for the non-healing of the tibia. They were planning to do an amputation because this woman was having tremendous amount of pain, wheelchair bound, and then they sent it to us to see if we have other thoughts about this problem. From a history related to bone and mineral metabolism, this woman has a parathyroidectomy 35 years ago at the time that we saw her. And she was, what is very important, this woman was on home hemodialysis. This woman is a very smart lady who really has a tremendous knowledge about end-stage kidney disease, take care of herself, super compliant with medications. And when we saw her, she was on home hemodialysis 4 times a week for 8 hours. She was taking some ergocalciferol, calcitriol only 0.25 micrograms a day. And then when I look at her medical records, what I noticed that for the last 2-3 years, really she has persistent hypophosphatemia. The serum phosphorus were around 2, with elevated alkaline phosphatase. Her PTH was only 53. I remember that she had previous parathyroidectomy. The 25s were within, up a little bit high, 76. The 125, it probably reflects her therapy with calcitriol. We measure also FGF23, C-terminal, and intact, that for dialysis patients, these values are kind of close to the normal range. And then when you look about the fractures, you can see that she has fractures here in the femur. That's the fracture that she has 8 months prior to the clinic visit here in the tibia. And you can see here, when I saw her in the clinic, her fracture was significantly worse. So when I thought about my thinking in this situation in a dialysis patient was it caught my attention, the persistence of the hypophosphatemia. So for those of you that not nephrologists, there is now, for the last few years, mainly in Canada, the Toronto group really emphasized the benefit of nocturnal hemodialysis, which has been, patients are at home, they can have dialysis, and there are significant improvement in many factors. But their group described that one of the problems with this degree of aggressive dialysis, that some of those patients develop hypophosphatemia. And some of these patients also require phosphate supplementation, which is kind of intriguing for dialysis patients, that we need to give them phosphate supplementation. So I thought, well, based on that, and I have to say that those data are biochemical data that have been described, but these have not been described the impact of that hypophosphatemia at the level of the skeleton. So we decided to do a bone biopsy in this patient, and you can see here, this little dark purple is mineralized bone. The rest, this is unmineralized bone, totally. You can see. And the tetracycline, there's no tetracycline uptake. So it's no question that this patient has severe osteomalacia. And so we decided to give her the treatment that was increase her phosphate supplementation. And the way that you do that in a dialysis patient, you need to put a lot of phosphate in the dialysate solution. So you use the fleet enema that it gives you reach a concentration of 1.3 millimoles per liter. And we increase a little bit the calcium in the dialysate. And she was hypocalcemic also, so we increased a little bit the dose of calcitriol. And it was amazing because I give this instruction to the nephrologist, and I didn't see this woman for a few weeks. Then a few weeks later, the husband called me to tell me that her pain, has been described in patients with osteomalacia, is markedly improved. He was very happy. And then when you look about the changes, you can see that the dark dot represents the change in serum phosphorus. And you can see here that the phosphorus really increased very nicely from the low 2s to the 4-5 range over a period of several months. And it's interesting, you can see that the level of FGF23 also increased, consistently as expected. And her alkaline phosphatase markedly diminished. And the serum calcium increased and, a little bit. And that's the rest of the values were expected changes in vitamin D. So clinically, this woman is improving. And I see her a few months later. She comes to my office walking, no pain, no wheelchair. And then we decide to repeat the bone biopsy. And you can see that her bone is markedly improved with this nice mineralization. Now she has some double tetracycline labeling. So the point of this really was the effect of severe hypophosphatemia in a dialysis patient. Although it's unusual, I can tell you that nocturnal hemodialysis is done more frequently now. Also in this country, daily hemodialysis is done more frequently. And so there are a number of factors that really people should be aware about the development, the consequence of this hypophosphatemia. So as you know, persistent hypophosphatemia is a critical factor in the pathogenesis of osteomalacia. And in this case, in this patient treated with maintenance dialysis, as expected, the FGF23 increased with phosphate supplementation, but within 12 months, the patient was pain-free, no longer to wear this leg boot, and she was walking without difficulty. So I thought that was an interesting case, and I'd be happy to answer any questions.
Please feel free to speak up.
Hi, Isidro, it's Mike. That was an amazing case. Can you go back? What were the FGF23 levels when she was
The first time it was here, the C-terminal 125 when we saw her, and the intact 55.
Huh. So, and then the FGF23 levels rose further as her phosphate rose. Well,
Exactly.
you know, those FGF23 levels in the setting of hypophosphatemia also point to that she has some primary or secondary defect in FGF23 physiology as well, don't you think?
You think because of the in which sense that is because of the but don't forget that it's a dialysis patient. So that it may
Yeah,
be
but it's a hypophosphatemic dialysis patient. And so, I mean, and that, I guess that's a question I have too. So does a patient who has had renal failure, goes on dialysis, gets a transplant, whatever, or a lady like this, do their FGF23 dynamics ever return to normal, or do they always have abnormal FGF23 dynamics?
The FGF23 immediate post-transplantation, they drop dramatically. And it's one of the factors why subsequently these patients but it takes a few months, but also don't forget that many of these patients develop hypophosphatemia, that it could be for two causes. One, high FGF, and two, high PTH prior to transplantation. And then what happened is over time, yes, it goes down significantly, but those patients, they don't have normal GFR. The GFR in a good percentage of these patients maybe are 50, 60. So it's not that you go to a GFR of 80 in the vast majority of the patients. So there is a component of, renal insufficiency that maintain the FGF23 up. What stimulates that FGF23, that is an important question, because when you look at patients with early CKD in the 40s, the first biochemical abnormality that we see is the rise on FGF, while PTH and 125, all of the 123 is a little bit low, but are normal. Calcium and phosphorus are normal. So we don't know what triggered this production of FGF23 by bone.
Did the orthopedic surgeons do anything about that femoral neck fracture, or did it heal on its own? You say she walked in a few weeks. I'm surprised that
He healed on his own. They didn't do anything. No, he didn't require any orthopedic surgery. Yes, he didn't require any orthopedic surgery subsequently.
That's an extraordinary statement given her age and the severity of those fractures. Phenomenal. Alrighty. Well, any last questions, folks? It's very stimulating cases, that's for sure. All right, if we don't have more questions, then to remind, Michael will be putting the link to the evaluation in as I'm speaking. Please be sure to go to the link and fill it out so you get your CME. Please be sure to join us next month, and we will do prenatal evaluation of skeletal dysplasias, which should be quite challenging. And last but not least, thank you so very much for such an extraordinary presentation, clear discussion, and great interaction. This has been a lovely night. Thank you so very much, Dr. Salusky.
Thank you very much for inviting me and hope to see you next month.
All righty. Take
Bye-bye,
care.
everybody. Bye-bye. It's nice to see you, everybody.
You see you.
Bye-bye.
Bye-bye.
That's for sure.
Take care. Thank you.
Yeah.
And just a reminder to everyone, I just put the link to the evaluation survey into the chat. And if people would like to save that or to bookmark it in their web browser, that is totally fine. This link will be used, it'll just refresh with different sessions each month. So you can just save it. Hey everyone, thank you so much. We hope you have a good afternoon or a good evening, and we will see you next month. Thank you.